So today we're going to talk about vascular compression syndromes, rings, slings, related things. So this is a group of anomalies that share certain similarities, particularly in their clinical presentation, but really have differences one to the other. And I think sometimes people get confused about the differences and how much different some of them really are. I think the other challenging thing that is related to vascular compression syndromes, they're often overlooked. They are characterized by symptoms that are seen very frequently in kids, swallowing problems, breathing problems that are often related to more common things. And so it's one of the last things people think about is an anatomic reason. But obviously important to understand what the anatomic reason is and to be able to diagnose it properly and then obviously treat it appropriately. So there are common features among all these vascular compression syndromes. They're all caused by vascular structures, be that systemic vessels, pulmonary vessels, or a combination of the two. And they compromise adjacent anatomy, either the airway, esophagus, or both. So we're talking about the great vessels, upper mediastinum. We're talking about compression of the airway and esophagus that leads to breathing or swallowing symptoms. There are similarities among the different types of vascular compression syndromes, predominantly in their clinical presentation and the tools that we use to evaluate these. But there are important differences, particularly in their embryology, which leads to their ultimate anatomy, and in the way we treat them. The treatment for some types of vascular compression syndromes is markedly different from that of others. And so for the remainder of the talk, I want to step through what I look at as four major but separate groups of vascular compression syndromes. I think a lot of people sort of lump things together and say these are vascular rings. Well, vascular rings, or what I would call true vascular rings, are really one of the four categories that we're going to talk about. The other three are aberrant right subclavian artery, the anomic compression syndrome, and pulmonary artery slings. So when we talk about the true vascular rings, it's important to understand the embryology of the great vessels, how they formed. And this diagram from an old text shows an early embryologic image of the aortic arches, which ultimately develop into the great vessels, the aorta, the pulmonary arteries. They are related to the pharyngeal pouches, the branchial clefts. There are parts that develop into named blood vessels that we see upon full development, the aortic arch, pulmonary arteries, and there are parts that involute. But schematically, it's a system of a number of arches. And in normal development, the distal part of the right arch, which is demonstrated here, involutes completely to give us our normal left aortic arch appearance with the characteristic branching pattern of the great vessels. A little more schematically represented, this is an image of what the early embryologic picture is. We have the aorta rising from the heart. There is a left arch and a right arch which come back together to form the descending aorta. And in most cases, there's a left ductus. Very rarely, and probably more commonly very early in embryology, there's a right-sided ductus. And then if we take this sort of three-dimensional conceptual picture and flatten it out a little bit, this is just another rendering of the same thing. And the trachea and esophagus are behind the proximal parts of the aorta and pulmonary artery, but then run in front of the descending aorta. So they run right through the center of that that ring. We'll come back to this image in a little bit, but when we talk about the true vascular rings, there are two main varieties. I like to tell parents sometimes they come in two major flavors. We have double aortic arch and right aortic arch with a left ligamentum, or some people will just simply say right aortic arch with a left aberrant subclavian artery, but not all right arch aberrant, or not all right arch left ligamentums have an aberrant left subclavian artery. It's just the most common of those variations. And in my experience, we see these two with roughly similar incidence. Maybe the right aortic arch left ligamentum group is a little more common than the double aortic arch, but these represent the two main groups. And within these, there's a little bit of variation, but they're two major patterns that are pretty similar in frequency. And so going back to the schematic diagram, if we look at the early embryologic representation depicted here of the double aortic arch configuration, in normal development, it's that distal right arch that involutes, leaving the subclavian and the innominate on the right to come off as a common first vessel from the ascending aorta, the innominate artery. The left carotid is the next vessel, the left subclavian is the last, and then the attachment of the ductus or ligamentum going down into the descending aorta. And it's certainly possible and not infrequent that you can have the exact mirror image opposite. If you lost the same segment of the left arch, you would have a right aortic arch with mirror image arch vessels. The ligamentum typically stays with the left subclavian artery, which in this case is coming from a left-sided innominate artery and remains an anterior structure. And this does not represent a true vascular ring because there really isn't anything going around the backside of the trachea and esophagus and nothing completely encircling those two structures. But the right arch variants of true vascular rings, it's the more proximal part of the right aortic arch or the left aortic arch that involutes. So the left subclavian artery arises from the descending aorta as the last branch. So as we step through the branching sequence, the aorta arises from the heart. The first branch is the left carotid. The next is the right carotid. Next, the right subclavian. The right aortic arch descends, and the left subclavian comes off the proximal descending aorta, and the ductus or ligamentum stays associated with that. So that's what completes the vascular ring. We have a right arch, a retroesophageal subclavian, and then a left-sided ligamentum attached to the pulmonary arteries back and front. It's possible, though, to have a mirror image branching pattern if we simply imagine that the part that involutes is just a little bit more distally on that left arch, leaving the ligamentum associated with the descending aorta, but leaving the subclavian associated with that proximal aorta. So we would have a right aortic arch with the first vessel coming off, giving off the carotid and subclavian, a left innominate, if you will. But then off the descending aorta, there's connection as a ligamentum. And what people often refer to as a Cummeral's diverticulum, we'll see pictures of this later, it really represents this distal left arch remnant that was a contribution of ductal flow as well. The ductus flowed into that, and that's what usually results in that being of larger size, even after the ductus closes, becoming a ligamentum. And so here are some artistic renditions of the two variations of true vascular rings. A double aortic arch, showing an arch that is complete around both sides of the trachea and esophagus. And in the majority of patients with double aortic arch, the right arch is dominant, the left is small, and may even for a portion of its length be completely atretic, still intact, as a fibrous band, but with no blood flowing through it. And it's typically the more distal part of that small left arch that becomes atretic, but there are certainly cases where they're actually close to equal in size. And as you might imagine, that's usually associated with more symptoms. But it's almost always the case that the right arch is dominant. And this is a rendition of that right arch with an aberrant left subclavian artery. We see it's depicted that that left subclavian artery is arising from the descending aorta, which you really can't see in the drawing, coming from the proximal descending aorta around the back of the esophagus, but the ring completed by the left-sided ligamentum arteriosum attaching the proximal left pulmonary artery to that left subclavian artery. Now, the presentation of vascular rings, the symptoms we see may be related to whatever they're compressing. The vascular anatomy itself doesn't impact the function of the blood vessels. The blood's still getting to where it needs to go, and in most cases there aren't any stenoses or alterations of blood flow. It's purely a function of the compression of adjacent structures that we see symptoms. And because these vascular rings encircle both the trachea and esophagus, we may see symptoms related to one, the other, or both of these structures being compressed. So we can see a variety of symptoms based on how tight the ring is, and a lot of fine different anatomical features. But from an airway standpoint, we'll see stridor. If stridor is the predominant symptom, it typically is something we see earlier in life in infants. And that makes sense. The airway is smaller in infants, and if it's compressed, it's going to result in symptoms. As kids get bigger, their airway gets bigger, resistance to airflow becomes less, and so if symptoms of stridor are going to present, they're usually going to present earlier in life when the airway is smaller. Dysphagia, on the other hand, problem swallowing, is often a symptom that doesn't show up until later in life. Kids are on liquid diets when they're first born, and liquids go down through the esophagus, even if it's encircled by blood vessels, fairly easily, but often as they transition to a more solid food diet, things start to get stuck. They have more difficulty swallowing through an area of relative stenosis, and symptoms start to become apparent. And then there are many cases nowadays where the vascular ring is detected as what some people refer to as an incidental finding. And it's a little tough to say whether it's truly incidental. It may be a child has a respiratory illness and they get a chest x-ray and the radiologist notices a right aortic arch and they delve in further and find a vascular ring. Now, did the respiratory illness that the child had that led to the x-ray represent a manifestation of airway compression? Who knows? But some of these kids won't have dramatic symptoms, classic symptoms, but we'll pick up on this anatomy. So how do we evaluate patients where we are suspicious of a vascular ring, or even if we know about a vascular ring? I think one thing that often is underappreciated is attention to the characteristics of stridor. If somebody's got noisy breathing, if somebody has stridor, the characteristics of the stridor can help to identify where in the airway the airflow obstruction resides. The more higher up in the airway, the more stridor is inspiratory. The further down in the airway, the more it's expiratory. The easy way that I remember is I remember asthma is classically end expiratory stridor. That's way at the end of the respiratory cycle, and asthma is typically way out in the peripheral airways. Whereas things above the vocal cords, above the larynx, are typically purely inspiratory stridor. Things like croup, things like a peritonsillar abscess, those are going to cause purely inspiratory stridor. And then at the vocal cords and the trachea, you're typically going to have biphasic stridor. You're going to have inspiratory and expiratory stridor. And that's really helpful in trying to characterize the location of the abnormality. Because a lot of these kids with noisy breathing, it gets attributed to things further down in the airway or further proximally, whereas they truly have biphasic stridor. You really have to think about central airway compression. I always like to examine the pulses carefully. Most kids don't have any pulse loss, but sometimes these variations may leave proximal stenosis of a subclavian artery, which may lead to a pulse loss or diminished pulse in one arm. And it's helpful to know that. And now we have better, really good imaging studies that can also clue us into that. But I think clinically it's important to know whether there's a pulse loss resulting from this unusual anatomy. It's important to listen for cardiac murmurs. Now, the vascular rings themselves won't cause a cardiac murmur, but some of these have associated intracardiac abnormalities that may need to be further investigated, and it's important to rule those out. Chest X-ray classically has always been a great screening tool for vascular rings. The vast majority of true vascular rings are characterized by a right aortic arch, and in many plain chest X-rays that may be easily visible. As I said, double aortic arches, the right aortic arch is almost always dominant, and obviously with the right aortic arch variants, there is a right aortic arch, and that's clearly dominant. And here's an example of a chest X-ray from a little bit older child demonstrating that finding. We see the airway. We don't see much mediastinal soft tissue to the left of the airway where the aortic arch would usually be, and it's really clear we see the knob of the aortic arch to the right side in this image. But in younger kids where they have a big thymic shadow, you may not be able to pick up the side of the aortic arch up at this level. It's also important to look further downstream because the descending aorta often causes a paravertebral stripe that we can see right down here that normally would be on the left side if you can see it. And if you see that down lower on the right side, that should clue one into the possibility of the presence of a right aortic arch. Barium swallows are often done in these children, particularly if they present with dysphagia or swallowing problems. It may be done as an evaluation for gastroesophageal reflux, which is the most common situation that people are thinking is going on. But then the swallow study shows a fixed compression of the esophagus. On the frontal view, we can see sort of an irregular appearance of the esophagus. It often seems to jog to one side. On the lateral view, there's clearly something vascular looking, indenting the back wall of the esophagus. So helpful study. Usually the barium goes right through. Again, it's liquid. It's not a high-grade stenosis. It's not surprising, though, that a piece of hot dog or chicken could get stuck there or be difficult to force through that area. And then nowadays, MRI or CT imaging has dramatically improved our ability to get detailed anatomic diagnosis before any interventional planning. So either MRI or CT both can yield excellent three-dimensional studies. They have the advantage of showing us the vasculature as well as the adjacent structures, the airway particularly. The esophagus may not be well seen. What's important to remember, though, when looking at an MRI or CT scan for vascular rings is that some of the vascular ring, particularly if there's a ligamentum that's a component of the vascular ring, which is very common, doesn't have blood flow in it anymore. So won't be visible on these studies because these studies are really looking at blood within a blood vessel, not the blood vessel wall itself. And so the ligamentum is unseen in these studies, and that always has to be kept in mind. But often these studies can show clues of where the ligamentum is because of an angulation of a blood vessel or the presence of a Kummerl's diverticulum. And so here's a nice example of a double aortic arch patient. And with these imaging studies, we can do beautiful three-dimensional reconstructions and isolate just the structures that we want to look at. So a double aortic arch with the right arch only slightly dominant compared to the left. And then finally, bronchoscopy. And many children may undergo bronchoscopy as an evaluation for noisy breathing before the possibility of a vascular ring has been entertained, but seeing pulsatile compression on bronchoscopy may lead to further evaluation with some of these other modalities, ultimately resulting in the diagnosis of the vascular ring. And so here's a demonstration, an anatomically normal trachea, but then very squashed, often asymmetrically, in the distal trachea. We can get a sense for some pulsatility. Typically, the bronchoscope can be passed through the area of narrowing without much problem. It's not an anatomic stenosis, it's an extrinsic compression, and then we push down to the level of the carina, but you can often still get a sense for that pulsatility, and sometimes even get a sense whether the pulsatility is predominantly anterior or predominantly posterior. Who should be operated on? Well, operation is clearly indicated in anybody with a vascular ring that has symptoms, and there's no, in my mind, ideal age. If a newborn is symptomatic, they ought to have an operation, and then obviously these things can present at a lot of different age groups, and there's no advantage to waiting for a child to get older. If their symptoms are really mild, and a family's not keen to rush off to the operating room, it's reasonable to wait a little while. If I had my choice, I'd probably say kids that are about a year of age are almost the perfect size. Their chest isn't so deep that it's easy to get to all the anatomy that you need to get to address. And I like to manage these things early in life, knowing that as the child grows, if any remodeling that needs to happen, shifting of the blood vessels back to a more normal position and off the airway is more likely to occur a little more quickly during that rapid growth phase in the early years of life. And again, the goal is to convert an O to a C. You've got to break the ring someplace to allow for expansion, at least out to one side. And virtually all cases of vascular rings are going to be approached through a left thoracotomy. And just a consequence of the fact that virtually all vascular rings have a dominant right arch, even if it's a double aortic arch. And so what you're going to divide is going to be whatever's on the non-dominant side, be it a ligamentum, a hypoplastic arch, and that's virtually always going to be via left thoracotomy. I like to be pretty compulsive about the monitoring of these children during an operation. I think it's partly a throwback to the time when I started doing these, and we didn't have the great imaging that CT and MRI scans have given us in recent years. You knew you had a vascular ring because there was a right aortic arch on chest x-ray, you saw compression on a barium swallow, but you really didn't know the exact anatomy, and the operation for repair was in part an operation for discovery. You had to define the anatomy in your surgical dissection, and having pulse oximetry probes on both arms and a leg, having a blood pressure cuff on the right arm and a leg helps in identifying some of the anatomy. If you see a blood vessel that you think is the left subclavian, well, if you can pinch it off and the pulse ox reading in the left arm goes away, then that's nice confirmation. And again, for some of these things where you may be dividing a blood vessel that is carrying blood flow in a double aortic arch, you want to make sure that where you're dividing things isn't compromising flow to the lower part of the body. And so the advantage of having upper and lower blood pressure, so you can do a test clamping at a point of proposed division before committing to dividing the blood vessel at that point. I still think it's always helpful to do a thorough dissection of the vascular anatomy. Even with good three-dimensional imaging, we know what the anatomy is. We can usually recognize the relevant anatomy with a more minimal dissection, but a lot of times there's advantage to dissecting the vessels out more extensively because it allows them to further move away from the structures that are leaning against the esophagus and trachea if you divide all those soft tissue attachments. So I think it's still valuable to do a thorough dissection for that reason, as well as to be able to really ascertain the anatomy. With a double aortic arch, we're typically dividing the distal left arch beyond the left subclavian artery, as well as the ligamentum, so really converting the anatomy to a right aortic arch with mirror image branching. With the right aortic arch variants, we need to divide the ligamentum, and that may be all that's needed. You may consider resection of a Cumral's diverticulum and reimplantation of the aberrant left subclavian artery to the left common carotid artery. The classic operation for this is simple division of the ligamentum. In recent years, some folks have gone to routinely resecting the Cumrals and doing a subclavian reimplantation. I've adopted that practice. It really, in my mind, it doesn't add a lot of complexity or risk to the operation. And we know that there are some patients that will have persistent symptoms with simple division of the ligamentum due to that persistent presence of a large blood vessel coming around behind the esophagus. And folks have shown that by going back later, resecting the Cumrals, reimplanting the subclavian, you can get relief of those persistent symptoms. In my mind, it's simpler to just go ahead and take care of it all at the first operation, really maximally unburden the mediastinum by getting structures off the esophagus and trachea as much as possible with that first operation when the dissection is simpler. So here's a surgical photograph of division of a double aortic arch. We've got the head's up at the top. This is posterior, this is anterior. We've got the opening in the pleura and dissecting out the mediastinal structures. See the descending aorta coming around from posteriorly, that's the right arch going into the descending aorta, that even though it's predominantly this may be a midline descending aorta, but even when the aorta is on the right side, it's surprising from the left how well you can see it sometimes. Superiorly, we see the left subclavian artery, and often when you start out, that's the only systemic arterial structure you can identify in the left mediastinum, and that's been dissected proximally and anteriorly where it's arising from the ascending aorta. This is the more hypoplastic left arch segment distally beyond the left subclavian going down to the descending aorta. And then also from that general vicinity is the ligamentum coursing anteriorly to the left pulmonary hilum. And we're going to divide that distal arch, divide the ligamentum, basically remove this segment, which is seen here, to let things spring apart. The descending aorta is moved posteriorly. The proximal left innominate artery now going to the left subclavian, also giving off the left carotid, is moved forward, and the stump of the ligamentum on the pulmonary end is seen, and the esophagus is readily visible below that. The trachea typically isn't visible from the left side of the chest. It's usually over further toward the right with respect to the esophagus. And this diagram represents the concept of, in addition to dividing the ligamentum, which is virtually always going to attach right at this spot. The reason that Cumral diverticulum is large, again, is because right now this part of the blood vessel is only supplying the subclavian. It's a lot larger than the subclavian, so you know at some time in a prior life it was carrying more blood flow than it's carrying now. The fact that that's large proves that there's something attached to that used to have blood flow, which is the ligamentum, and that's why that's large. You can predictably identify the ligamentum coming off here, and once you've divided that, then the Cumrals can be resected. Sometimes you got plenty of length. The bulbous part can be removed, the aortic end oversewn, and the subclavian artery moved anteriorly and anastomosed to the left common carotid artery. I have often done these repairs preferentially through a left fourth interspace thoracotomy. It gives good exposure to the area of the vascular ring, but as we've moved to doing more routine resection of the Cumral's diverticulum and reimplantation of the subclavian artery with these right arch aberrant left subclavian variants, we've moved up an interspace to the third interspace, which gives you plenty of good exposure to the vascular ring anatomy, but it gives you much better exposure for the dissection of the carotid and the reimplantation and anastomosis of the subclavian to the carotid. Most patients with division of vascular ring will have relief of their symptoms pretty promptly. It'll be pretty noticeable to the parents. Obviously, the more symptomatic they are, the more you might expect that their symptoms will be improved. But in many cases, some of the symptoms may persist, and we should expect to see a more gradual relief of some of the symptoms, partly because in some of these patients there may still be some retroesophageal vessels that may still cause some issues with swallowing. Even with resection of a Cummeral's diverticulum, some of these children may have a midline descending aorta, or what we call a circumflex descending aorta, where they have a right arch, but the proximal descending aorta crosses behind the esophagus and the descending aorta is on the left side of the chest. And that may result in persistent symptoms even if you do reimplant the left subclavian artery. Some of these kids with important airway compressions right from early in life may have significant tracheomalacia, and that doesn't get better right away. In time, as they grow, as the tracheal cartilages firm up, the tracheomalacia may gradually improve. And then some kids, predominantly those that I've seen with very long-standing vascular rings that haven't been diagnosed early, may end up having some esophageal dysmotility. So even in occasional cases where I've seen we've moved the blood vessels completely off the esophagus, they may still have some swallowing issues that don't appear to be compression anymore and presumably are resulting from some persistent dysmotility. So now we're going to move to the next group of vascular compression syndromes, the aberrant right subclavian artery, which a lot of people think, well, this isn't a vascular compression syndrome. These don't cause symptoms. And while most of the time that's true, that's not always the case. And an aberrant right subclavian artery, so a left arch, but a right subclavian that arises from the descending aorta taking a retroesophageal course, a little bit analogous to some of the anatomy we've talked about already with the vascular rings, is actually fairly common. Nobody really knows for sure what the incidence is of this in the general population. It's estimated to be up to 2% of the general population. We know that it's actually quite common with trisomy 21. In about a quarter of kids with Down syndrome, there's an aberrant right subclavian artery. And I think most people agree that the vast majority of these cases are asymptomatic. This is not a true vascular ring. There's an aberrant right subclavian going behind the esophagus, but the ligamentum is still over on the left side. The ligamentum is still under the aortic arch to the left subclavian artery, or the left pulmonary artery typically. And so there's not anything that's closing the ring on the right side of the chest in these cases of a left arch with an aberrant right subclavian artery. And thus, as you might expect, it's largely asymptomatic. People used to use the term dysphagia lucorium or hysterical dysphagia. That was the descriptor of this, that some people would get swallowing difficulties, that they'd feel like something was stuck or pulsatile in their throat when there was this aberrant right subclavian artery, but most people would tolerate it quite well. Generally, these are not associated with a Cummeral's diverticulum. Again, they're generally not associated with a right-sided ductus. That's exceedingly unusual, so there wouldn't be expected to be a right-sided Cummeral's diverticulum, and that means the part of the vessel that's going behind the esophagus usually isn't expanded and largely likely not causing as much compression of the variant with the right aortic arch. And these are often incidental findings. We may pick them up on a barium swallow when kids are having some swallowing difficulties and you see a posterior indentation, or on a CT or an MRI that may be done for other reasons in some cases. But again, CT and MRI do a wonderful job of showing the anatomy, and that's usually what we rely on to use for a roadmap for intervention. Here's a picture of a typical diagonal impression on a barium column in the esophagus. on a child being evaluated for swallowing difficulties. And here's some of the 3D imaging. So again, to compare these two, the aberrant right subclavian artery, both these posterior views, left arch, aberrant right subclavian artery, the caliber of the vessel is pretty uniform. It's maybe a little bigger at its origin, but it's a pretty straight shot up to the subclavian territory. Compared to the right arch, aberrant left subclavian artery, we've got this large Cummeral's diverticulum, which is larger in caliber than the left subclavian artery that continues. You've got this bend in the vessel, which indicates there's something tethering that. Well, that's the ligamentum completing the ring on the left side. And then again, in the case of the right aortic arch, in the case of the left aortic arch, aberrant right subclavian artery, there's no ligamentum on this side. The ligamentum is going to be under the arch over there. And so when do we deal with these? Most of these are going to be causing swallowing problems. It would be highly unusual, not impossible, to cause any airway-related symptoms. And because the age of children that usually we're looking at with considering doing something in this anatomy are younger, there's usually a lot of other reasons why they may have swallowing difficulties. Gastroesophageal reflux, obviously very common in the young age group. And so I think it's important before considering operation in these children to rule out other reasons for their symptoms, because sometimes the symptoms are, vague, typically not very specific. And there are really no studies that we can do to absolutely confirm the fact that the symptoms are related to the anatomy. You're going to see an impression on the esophagus if you do a barium swallow. That doesn't necessarily tell you that things are hanging up, because with a barium swallow, things usually don't hang up and they'll go right on through. But if other reasons have been ruled out, if somebody still seems to have significant symptoms, I think it's a very reasonable approach to move that vessel from its retroesophageal course via right thoracotomy, do a reimplantation of that right subclavian artery, take it off the descending aorta, move it forward, and connect it directly to the right common carotid artery. Very similar to what was seen in one of those earlier slides that we do for the vascular rings of right arch variation. Next on the lineup is the innominate compression syndrome. It's a term that I really dislike. I'll explain that in one of the upcoming slides. But innominate compression syndrome, so the concept that the innominate artery, first vessel off the aorta, is anterior to the trachea and leaning on the trachea and causing airway compromise. Usually, if this is going to be symptomatic, it's typically in infancy. It's going to be younger kids. It's going to be kids that have smaller airways. And the symptoms, as I just mentioned, are typically airway symptoms, not swallowing symptoms. This is all an anterior process. We see stridor, we may see apnea, we may see these acute life-threatening events. Very similar to some of the constellation of things we see with bad gastroesophageal reflux. So sometimes very difficult to differentiate them. I think what's most important about this entity is that it's multifactorial. And that's part of the reason I don't like the term innominate compression syndrome, because it tends to imply that there's something abnormal with the innominate artery. And while the anterior position of the innominate artery going across the front of the trachea is a contributor to the problem, it's really not anything abnormal about the innominate artery. The innominate artery is always anterior to the trachea. There have been studies that show the normal course of the innominate artery in the human body is it starts to the left and goes across to the right of the midline, anterior to the trachea. I think the underlying pathology is really related to the trachea. These kids have more pronounced tracheomalacia than usual. And the other feature in this age group is they've got a very large thymus. So in the upper mediastinum, you've got the vertebral column pushing in from behind. You've got a large thymus in the front, a blood vessel under systemic pressure, and of course the structure that's least likely to be able to protect its domain is the trachea, and it ends up losing out. I think it's always important to remember this is a multifactorial problem and not just a problem with an unusual innominate artery. The evaluation of innominate compression syndrome a lot of time hinges on bronchoscopy. It's a good clinical history. Obviously, you're not going to proceed to evaluating and considering intervention unless somebody's got pretty pronounced symptoms. But a bronchoscopy helps demonstrate the level and the severity of the narrowing. And then I think it's also helpful in these cases to do imaging of the chest with CT or MRI. It can give you a sense for the spatial relationships of the great vessels with the airway, and the size of the thymus, and what room you have inside to be able to reconfigure things potentially surgically. And it's also important to rule out other vascular compression anatomy. As we've said from the beginning, this group of entities all have very similar symptoms, and it's very difficult on clinical evaluation to differentiate a true vascular ring from innominate compression, but a CT or an MRI certainly can differentiate those quite well. And so here's an image of a bronchoscopy of a child. We've got a membranous trachea poking in. We've got about mid-trachea level, we start to see some impressive compression. It's not really visibly pulsatile at this point. Very impressive how much compression there is. The trachea is squashed. Now, this is clearly not a normal trachea. The cartilages are not doing their job of holding that open. Now the bronchoscope's been able to push through, and now with the bronchoscope in the middle of the compressed area, we definitely get a sense for the pulsatility that's associated with the compression of the trachea. And it's not surprising, most cases with tracheomalacia, whether it's mild compression or not, are going to see some pulsatility because the trachea is adjacent to blood vessels. So the fact that there's pulsatility doesn't always necessarily implicate some abnormality of the blood vessel as the problem, but in moving the blood vessels around may actually turn out to be part of the solution in a lot of these cases. And so here's some images from a CT scan as we start at about the level of the aortic arch. First, we see a fairly large thymus. As I was mentioning before, the trachea is right behind the ascending aorta, and as we step more superiorly in the mediastinum up to the top of the arch, we're starting to see the three arch vessels arise. We're starting to see a little more compression of the trachea. But we can see at this level the real estate in the mediastinum medially in the center here is relatively limited. We've got the spine pushing in pretty prominently posteriorly. We see a fairly big thymus taking up a lot of space, and then these blood vessels, the vein obviously is not going to push too hard, but these arteries certainly will. And again, the trachea is sometimes lost in the middle. We push up a little further and we can see that takeoff of the innominate going across in front of the trachea. And so the treatment for innominate compression syndrome, time favors spontaneous resolution of the symptoms. In my mind, it's really a lot like gastroesophageal reflux in kids. A lot of kids have gastroesophageal reflux. Most kids grow out of it in the first year or so of life. Same is true for this. It's a problem of tracheomalacia. A lot of kids have it. Most kids, as they get older, as the trachea gets bigger, as the tracheal cartilages get stiffer, they grow out of it. Just like with gastroesophageal reflux, you got a small percentage of patients that have important, potentially life-threatening symptoms. And that warrants a more aggressive approach, potentially with surgical intervention. So with apnea, life-threatening events, or severe tracheal narrowing more than 50% by bronchoscopy, that would warrant intervention. And typically the type of procedures that are done for this are aortopexies. We're moving things around. We're not actually addressing the underlying problem, which in my mind is the tracheomalacia. There's not a lot we can do for that. We just want to get the trachea a little more room, move the things around that are pushing on the trachea. And so the thing that seems most likely to be able to be moved is the blood vessels. But what's important to recognize is you're also doing a near total thymectomy, and that in and of itself may be as important a feature of the operation as moving the blood vessels around. You can do an aortopexy, and we're talking about an anterior aortopexy, bringing the innominate artery aortic junction anterior up against the back of the sternum. And that can be done via a mediastenotomy approach. I've done these through the resected bed of the second costal cartilage anteriorly, just parasternal. People have done them through the left thoracotomy, right thoracotomy, or even video-assisted techniques. But you're typically going to remove part of the thymus and then suspend the aorta. Rarely people have described innominate artery translocation. Need to go in through a median sternotomy, presumably, take the innominate artery off, move it to the other side of the aorta so that it's not crossing in front of the trachea. That's a situation I would only consider if there wasn't room to move the blood vessels anteriorly. And that's where the CT scan or the MRI can help sometimes, because you can see in that study, usually, like we saw in the examples that I showed on an earlier slide, that there's often a lot of room to move the vessels forward to the back of the sternum, particularly when you get that thymus out of the way. And that can often suspend the trachea open. And it relies on the fact that you're not dissecting between the trachea and the vessels, that when you pull the vessels forward, you're tenting the airway open. And so here's a diagrammatic representation of an aortopexy, taking some stitches at the junction between the ascending aorta and the innominate artery, and pulling that forward by bringing the stitches up through the manubrium and tying them on the outside to pull that area forward. Personally, I've never been really keen on putting stitches in blood vessels and putting great traction on them. It worries me about bleeding, and I have always liked a technique of a pericardial flap. So in this technique, you've made a sort of a U-shaped cut on the pericardium in front of the aorta. The pericardial reflection is often right at the aortic innominate junction, and in some cases you can't pull that blood vessel all the way forward to the sternum. It would distort the blood vessel. Well, that you've got to flap a pericardium. You can pull it partway forward. And even if you can pull it all the way forward, I like to put my stitches in the pericardium and pull that forward rather than pull the aorta itself forward. And so here's some images of a bronchoscopy done before the aortopexy and after. So seeing that airway has been better suspended open. Post-op bronchoscopy can often be helpful. A lot of people advocate that you need to do that, or you can even do it while you're pulling things forward to confirm that you're adequately improving the caliber of the airway. But I think it's also really important to remember that the tracheomalacia itself is not being addressed with an aortopexy, and so some persistent stridor is common, but again, it should improve over time. We're trying to get these children out of the danger zone, out of the range where their airway collapses to the point where they're having serious life-threatening events. They're still going to have some noisy breathing, and that should get better as they get older. And then last but not least is the pulmonary artery sling, and this diagram represents the typical anatomy of a left pulmonary artery sling. Instead of arising from the distal main pulmonary artery, the left pulmonary artery arises from the right pulmonary artery and then takes a course posteriorly around the trachea, so forming a sling around the trachea, going between the trachea and the esophagus to reach the pulmonary hilum. These kids will often have a ligamentum in a normal location, so it almost forms a ring around the trachea itself. So it's an anomalous origin of the left pulmonary artery from the right PA, and the course is between the trachea and esophagus. It's about the only anomaly where a structure will be seen between the trachea and esophagus. And the size of the left pulmonary artery may be variable. In my experience, most cases of left pulmonary artery sling, the left pulmonary artery is a perfectly normal size, but there's some cases where it's quite hypoplastic. The real key thing to understand with left pulmonary artery slings is the frequent association with true anatomic tracheal stenosis due to complete tracheal rings. Over 80% of patients with LPA slings will have a tracheal stenosis. And while you might imagine that tracheal stenosis is at the distal end of the trachea where the left pulmonary artery is slinging around the trachea itself, it's actually fairly common that the stenosis begins distally, but it can extend for a variable distance proximally, and very often the entire length of the trachea may be involved with complete tracheal rings and tracheal stenosis, despite the fact that the vascular anomaly is really only around the distal trachea. The symptoms with LPA sling are largely dominated by the degree of tracheal pathology. When there's not true tracheal stenosis, there can be tracheal compression and there can be airway symptoms. Stridor is often noted early in life. These patients may not be diagnosed until a couple of months of age when they get their first good viral illness that increases the secretions and exacerbates the problem of a compressed or small airway. But in retrospect, most of these kids have been noisy breathers from almost day one. The PA anatomy itself is of no hemodynamic significance. It doesn't have any impact on blood flow to the lungs. It doesn't have any impact on the function of the right ventricle. So the evaluation of these patients is going to always include an echocardiogram. Often the vascular anatomy can be identified with an echocardiogram, but it's not always easy. The further away from the heart you get with an echocardiogram, the less easy it is to define some of the vascular anatomy. So not seeing a left pulmonary artery in a normal position doesn't necessarily imply there's a pulmonary artery sling, because the left pulmonary artery often is difficult to see well. But sometimes the anomalous origin of the left pulmonary artery from the right pulmonary artery is visible by echocardiogram and can help raise suspicion about the diagnosis. But it's important also to rule out any associated intracardiac anomalies. While these may not be seen very frequently with an LPA sling, they would be managed at the same time, because an LPA sling, along with any associated tracheal stenosis, is going to be repaired via sternotomy using a heart-lung bypass machine. CT or MRI with 3D reconstruction is going to be very useful for defining the vascular anatomy and the tracheal branching. I don't rely on these studies to identify the presence of a true tracheal stenosis. CT and MRI can't really well differentiate tracheal stenosis from tracheal compression. And it's not got the resolution to really see complete tracheal rings. But some of these kids will have anomalies of tracheal branching, say a right upper lobe bronchus taking off the mid-trachea, a bronchus suis or a pig bronchus, and then an area of complete rings down to the true carina, and it's at that level that you see the pulmonary artery sling. Bronchoscopy is essential for any child with a pulmonary artery sling. That's the study that is necessary to define the tracheal anatomy. That's what you can see, these complete tracheal rings, but you have to have an experienced bronchoscopist, because this can be a hazardous diagnostic study. If you rough up a small airway and cause edema, you're going to compromise airway, and you can sometimes take a somewhat well-compensated but tenuous situation into a situation where you don't have any ability to manage the airway. And so here's some examples of CT imaging showing on the axial views the pulmonary artery arising from the right ventricle. Left pulmonary artery normally would be coming off at this location. Instead, we see the right pulmonary artery coming around behind the aorta, and the left pulmonary artery arising from it and coursing around the trachea to come back over to the left hilum. And then a 3D reconstruction on the right here, where we see the main pulmonary artery left PA would normally be coming off here. Instead, we see it coming off the right pulmonary artery and slinging around. And you do get a sense that the distal trachea is small. And you almost see this little nub in here, which probably represents what would have been a right upper lobe bronchus, but sometimes is atretic. And some of these kids, the right upper lobe may be unformed, and there may just be a blind stump of what would have been a right upper lobe bronchus and a somewhat hypoplastic lung on that side. And this is a demonstration of a bronchoscopy from a patient with a complete or a tracheal stenosis with complete rings. Upper part of the trachea looks okay. Here we've got a pig bronchus. It's full of mucus going off on the right and right upper lobe bronchus, but just below that we can see complete tracheal rings. No membranous trachea posteriorly. In this case, a segment of about 3 or 4 complete rings, and then down at the carina we start to see a membranous trachea again. But again, as we pull out, we'll see posteriorly we've got complete cartilaginous rings going all the way around the airway associated with small caliber. And so in the case of an isolated pulmonary artery sling, presumably it's symptomatic because of compression of the airway. Historically, people would approach these via left thoracotomy and perform a reimplantation, but there was a very high restenosis rate. And it's pretty difficult to do an adequate reimplantation through a left thoracotomy, particularly in a small child, successfully. And some of it may have been related to the type of sutures they had at that time and not. But nowadays, the approach typically is anteriorly using cardiopulmonary bypass support, mobilize that vessel, reimplant it to the main pulmonary artery, and the results are very good with a very low restenosis rate. But again, isolated pulmonary artery sling is the minority of patients with LPA sling. Most have associated tracheal stenosis, and the repair is going to be addressing both of these problems, reconstructing the trachea using slide tracheoplasty technique, using cardiopulmonary bypass support, and managing the left pulmonary artery sling at the same time. And my preference is to perform a reimplantation of the left pulmonary artery over to the main pulmonary artery. Some folks have said, well, you can just do a translocation. So if you are going to take the trachea apart and put it back together, you can just move that anomalous left pulmonary artery in front of the trachea in doing so, as is seen in the right panel here. The problem is, the couple times I've seen this happen, it's been disastrous. The left pulmonary artery, when it's taking a long course coming off at an odd angle from the pulmonary artery over on the right, if you just push it forward, the chances of it kinking or still causing compression on the front of the trachea is fairly high. And it's far superior to just take it off, move it over, reimplant it, keep things off the front of the reconstructed trachea as best as possible. And the results for management of pulmonary artery sling, from a pulmonary artery standpoint, typically very good. As long as there's no underlying hypoplasia of the vessel, that anastomosis typically grows well. We usually use absorbable material for sewing them. It's a artery to artery anastomosis, and in most cases it grows quite well. Restenoses are relatively easy to identify and actually can be managed in the cath lab if they occur, but that's rare. So the tracheal pathology is the major influence on morbidity and mortality. Historically, that was a big deal. Nowadays, with the popularity of a slide tracheoplasty and more experience with that technique, the results of the tracheal reconstruction are good, the survival is excellent, and the incidence of later problems with the airway is relatively low. And that wraps it up, so thank you for your attention.